But Sara Andrews, DDS-MS, is a full-time orthodontist and sole practitioner at Andrews Orthodontics. In addition to private practice ownership, Dr. Andrews is an assistant clinical professor at the University of California, San Francisco, Department of Orthodontics, where she teaches the practice of orthodontics to specially programmed residents. Dr. Sara Andrews received her DDS degree in cum laude from the University of California, Los Angeles, School of Dentistry, and, can we say it? 2010. She completed her orthodontic specialty training at the University of California, San Francisco in 2013. In addition to orthodontic certification, Sara Andrews has also obtained a Master's of Science degree in oral biology and craniofacial science from UCSF. Dr. Sara Andrews is a diplomat of the American Board of Orthodontics, which means that she has successfully completed their ABO examination and certification process. Without further ado, she's going to present on clear aligners, the ins and outs of virtual treatment planning. And I'll turn the meeting over to her.
Thank you. Thanks, Brad, for the fabulous introduction. Thanks for being here, everyone. So our objectives for tonight's presentation are being able to distinguish between ideal versus challenging case steps for clear aligners treatment, understand the basic biomechanics of tooth movement in clear aligner therapy, how to properly utilize attachments and IPR to improve efficacy, how to increase treatment efficiency, and avoid undesired side effects. These are all things we all want, right? A little about me. Brad did a really good job introducing me. So graduated 2010, 2013, and I've owned a private practice since 2015 here in San Carlos. I've been on the San Mateo County Dental Society Executive Board since 2018. And I recently, starting January, started teaching at the orthodontic clinic at UCSF, which I really enjoy very much, and I highly recommend all of you to get involved giving back to your profession at some capacity. It's just very, very fulfilling. This is my family. This is in front of Garwood's restaurant in Tahoe. It's like one of my favorite restaurants, a lovely place. This little guy right here is now huge. That's our dog. We got him as a Christmas present for the girls, so it's been really, really fun. It's like having another baby all over again. My treatment philosophy, Dr. Earl Johnson's one of my mentors at UCSF. He passed away, unfortunately, due to a terrible bike accident a couple years ago. But he had the best sayings when it came to orthodontic treatment philosophy. One of them was keep it simple, stupid. Of course, he didn't invent that, but it just really resonates with me on a day-to-day basis, and I really think that's very, very important. Keeping it simple, yet efficient and effective, it's really what we all need to be doing. And so effective, I learned these two quotes right there from Maz Mashiri, a really big orthodontist, talks, a big speaker for Align. He said, effectiveness consists of doing the right things. Efficiency requires doing things right. When systems are more effective and efficient, they deliver great productivity by doing the right things right. And that's what we're trying to achieve with everything that we do in our practices every day. That should be our goal. Keys to treatment success, really any treatment. First thing you need is a clear diagnosis. So diagnosis, when I see a patient, it has to be comprehensive. I'm not just looking at their crooked teeth. I really need to look at their periodontal condition. I really need to look at their caries history, their risk factors, and whether this person is going to be a good candidate for orthodontic treatment or not. We need to have clear goals and objectives, and your goals and objectives must align with the patient's goals and objectives. That is huge. If somebody comes in with a posterior crossbite and their concern is a lateral that's a little rotated, you need to be very clear about and make sure your goals and make sure that they align with the patient's goals. Clear patient expectations, so inform before you perform. Invisalign treatment creates black triangles. Really, any kind of orthodontic treatment, when you strain teeth that have been crowded for decades and that papilla is no longer there, they're going to get black triangles. So you better let them know about that before you start any kind of orthodontic treatment, because they won't be happy at the end if they see those spaces. Why do I have gaps in my teeth? Well, you don't actually have gaps between your teeth. You know, your teeth are touching, so you don't have gaps, but sometimes you have to go into an explanation. So I tell every single patient on day one, you're going to have straight teeth, but you're going to have these windows. I call them these windows. And I just use my hand. I go like this. Well, your teeth are like this, and then they're going to go like that. And then guess what? You're going to have a window where your gum is no longer present because they've overlapped for so long that your gum's gone out. It's disappeared. So there are ways we can manage it. There are ways we can minimize those black triangles, but I can't get rid of them. So expect that that's going to happen. So you're going to tell them every single thing. You're going to tell them which teeth they're going to have attachments on before you put the attachments on them. Because it still happens to me. Patient comes in, I have this many attachments, I might as well should have gotten braces. Like, wow. So I tell my patients now, you're going to have attachments on pretty much every tooth. And I'm going to go into why I like so many attachments. Okay, you want your treatment plan to be efficient. Again, keep it simple, work smarter, not harder. And then you need to have a very clear retention plan. You have to lay it out to your patient day one. You're going to have black triangles. You're expected to wear these 20 hours a day. We're going to need to IPR. Your teeth are going to shift if you don't wear your retainers. You're going to have attachments on every tooth. You have to really lay them out clearly. Otherwise, you may not have a happy patient at the end, even though you've achieved optimum results, okay? So success, and so here's my treatment philosophy: deliver the best. That best, there's no real definition of best. You know, we all think about, even if you think you've done your best work in the eyes of your patient or in the eyes of the referring dentist, that may not be your best work. So how do you define the best? To me, the best result is the goals that I've laid out with my patient right at the beginning. If I can achieve those goals, and you have to be very, very clear, and you have to clearly document it, if you've achieved those goals with your patients, that's the best results, because that's the optimum results that you've achieved for them. And this is the key, shortest amount of time with the best patient experience. Their experience, a lot of times, is more important than what happens in their mouth. The way they perceive your office and the way they perceive how they were treated and how they felt in your practice, a lot of times is more important than straight teeth. So 3 keys of orthodontic treatment success: case selection, huge; treatment plan, huge; and your patient compliance. With any orthodontic treatment, you need patient compliance. I tell my patients, orthodontic treatment is a two-way street. I need you to be on my team to get to where we want to be. And then, of course, efficiency also involves technology. You have to have the right technology. If you do any kind of clear aligners at all, you need to have one of these. You gotta have it on. Or I think for dentists, even like crowns and pros work, it's been a real game changer in my practice. We're completely now impressionless. Completely, we don't take. The only time I will take impressions is for orthodontic cases, because I still like the handheld surgical models, because I like to look at them. But other than that, we don't take impressions at all. For all of our retainers, I actually send everything through the scanner digitally to the lab, and then we submit a prescription. Even my Holly retainers, all my expanders, we make it from this. We don't at all take impressions, which has really increased efficiency. My assistants do not take impressions, and they don't trim models anymore. They're just so spoiled. Like, they love it. I mean, why wouldn't I do that? You know, it costs me a couple bucks more, but then I have happier staff. I don't have as many employees as I would have if I had to do all that lab work. So we're very lean and clean, and of course the patients perceive it as a very high-end office and good experience. So my treatment protocol, we place all attachments at stage 1. If you look at your ClinChecks, if you do Invisalign, you'll see, like, you're watching the video, the ClinCheck, and then suddenly an attachment appears, a power ridge disappears, and an attachment appears. No, don't do that. Put all of them at stage 1. Remove all the power ridges if you need to, okay? I perform all my IPR at stage 9 except if they're not still fully aligned and I wait a little bit longer. The reason for that is that first appointment, you're doing a lot to that patient. You're showing them the ClinCheck. You're putting attachments on them. You're spending 20 minutes talking to them about this is how it works. They're already overwhelmed. I don't want to now be sanding down their teeth at that same appointment, right? Again, enhancing patient experience. The reason we do it at stage 9 is that we always give them 8 aligners at a time, and we see them back every 8 weeks. So they change their aligners every week. So it just works out really well from many standpoints. So I tell them change your aligners every 7 to 10 days. Why is there a range? Well, if at day 7 you feel like your aligners are still active, there's still movement built in, and you're not ready to move on, wear them for an extra 3 days. I don't really want them changing them every 2 weeks because teeth need continuous forces, and you got to keep that momentum going. If you give too much break, and then they also kind of, changing 2 weeks is hard to keep track of than weekly because every Thursday I'm going to go to the next one. Easy to remember, right? So I tell them I'd rather have you change them every 7 to 10 days, even if you're not getting the optimum hours, but don't go to 2 weeks because they also get lazy. You lose momentum. So use aligner seeders, the little chewies, munchies, crunchies, whatever they're called now. There's so many different kinds. And then additional aligner scan with attachments on. So I used to remove all of my attachments, do a refinement scan, and then come back and put new attachments on. Completely inefficient. We scan with attachments on, and we set up that high-speed handpiece only once. So we scan with all attachments on. I virtually remove them if I need to. I replace them, and then when they come back to what we call it the refinement or additional aligner delivery, that's when we bond new ones on. So you're setting up the handpiece one time. Again, efficiency, right? And I used to remove all of them. Now I only remove selective ones. And we'll talk about that. This is important. Optimized attachments versus conventional attachments is important. Is this good for all you guys? Is this helpful what I'm talking about? You all interested about learning different attachment types and everything? Yeah? I think so. I thought so. Okay. So my goal was really kind of to share with you all, especially ones who do some Invisalign treatment, kind of the nitty and gritty of ClinCheck. Okay. So what cases are good for aligner cases? Mild to moderate crowding, moderate overbite, overdepth, protrusive maxillary incisors, or any kind of protrusion. If you're protrusive, that's a good aligner case because aligners are really good at bringing things in. They're not as good at torquing things out, right? So if you have an anterior open bite, easy peasy, awesome for aligners. If you have a class 3 is a little bit better than class 2. And then if you have mild to moderate curvus B, that's good. If you have a partial crossbite, if you have a single tooth and crossbite, even an upper molar and crossbite, easy peasy aligner case, okay? What's hard, and I encourage everyone to stay away from these unless you really know what you're doing and you're very clear about your the patient's expectations. If you have a tooth that's blocked out, you may, completely blocked out. If you have a canine that's completely blocked out of the arch, like a lower mandibular canine that's completely lingual and rotated 90 degrees, do not do it. You need some auxiliary, you need some braces first. If you have a very deep bite with none to minimal mandibular arch crowding, don't do it. Because how are you going to open that bite? There's no crowding. You can't procline the lower incisors, and I'll show you an example of that. If you have a skeletal class 2, if you have somebody that's truly retrognathic in the mandible, and then they may have 100% deep impinging bite with no mandibular crowding, tipping those lower incisors you're not going to go anywhere because you have a huge sagittal, you have a huge anterior-posterior skeletal discrepancy. It's just not going to work. If you have really those class 2 division 2 cases where the teeth are really tipped back, torquing incisors is not easy with aligners. It's doable, but you need a lot of overcorrection built in. It's hard to do. If you have severe canine and premolar rotations, I still struggle with them. they're not easy to do. Posterior open bite. If you have a posterior open bite, for whatever reason, usually a lot of times it's caused by a weird night guard that they wore at some point. It's iatrogenic. Usually people don't have posterior open bites. It's mostly iatrogenic. I'm talking about like a complete posterior open bite where nothing touches in the back. I have seen a couple of cases where he swears that that's how his bite's been his whole life. But usually that's not something that we see. Don't try to do that with Invisalign. It's very, very difficult to correct. And you have a deep, deep mandibular curve of SPE. So that's your number one contributing factor to a deep bite or a class 2 case with a very deep mandibular curve of SPE. Don't do it with Invisalign. Okay, maybe do braces on the lower. Full posterior crossbite. If somebody has a full posterior, not just one tooth in crossbite, full posterior crossbite, it's questionable. Just don't do it. Short clinical crowns. Some people have little itty bitty teeth. The plastic just cannot grab on. No matter even if you put attachments on, it just doesn't work. I've struggled really hard with some of those cases, especially itty bitty teeth with a rotated canine. Good luck getting that canine to turn. It's really difficult. Anyway, so there are some inherent deficiencies to every tool we have. Aligners are just a tool. It's not, there's nothing magical about them. It's a piece of plastic. You just have to know what it's good at doing and what it's not good at doing. So there was a study here in 2018. So they looked at the clinical outcomes with what was predicted on ClinCheck. Aligners are just not good at canine rotations and intrusions in general, incisor intrusion, canine rotations. And newer study came out, premolar rotations. You could just never get it as good as braces. I'm sorry to say, no matter who you are, if you're like Diamond plus provider, you're still the best operators limited by their tool. It's just, your premolar rotation, I struggle with them. People don't notice them. So I'm gonna be honest with you, sometimes I just okay, it's great, you look beautiful. The teeth are great, they look amazing, the bite's good, but then that premolar still has a little bit of rotation. The patient doesn't see it, and I just can't 100% get them a lot of times, and that's just an inherent deficiency of Invisalign. So Invisalign is not as good as braces at certain things, and braces are not as good as Invisalign at certain things. Let's be very, very clear about that, and I think with all the marketing things that go on, it's really easy to lose sight of that, but it's the truth, okay? So let's talk about the maxillolateral incisor. Everyone's favorite tooth, right, with Invisalign? Okay, so there's a study that looked at exactly that, effective clear aligners, attachment design on extrusion. So a lot of times maxillolateral incisors need extrusion, right? What does the patient tell you? So this is actually talked to a prosthodontist that refers to me, and we were trying to idealize implant size for 7 and 10, and he mentioned to me, well, 7 and 10, one of them's about 0.5 millimeter, the space is 0.5 millimeter wider than the other one. And I thought about this, I've never ever had a patient come to me, my office, and say, oh, my 7 and 10, one of them's wider than the other. Ever. No one's ever said that. But they will always say, my laterals are shorter. The length of the lateral is something that stands out to them, not even up to a millimeter discrepancy in the width of 7 and 10. They don't see that. But so extrusion of lateral, a lot of times we have to extrude and rotate our laterals with aligners, right? So they looked at the different types of attachments, and they looked at a horizontal attachment versus an optimized attachment. So this meeting is sponsored by Align. My rep is Jenny Chang. She's awesome. And I have no, disclosure, I don't get paid by Align. But I only use Invisalign. I don't use any other aligners. But Invisalign, you go to their meetings, one of their biggest selling points is their optimized attachments. Okay, so optimized attachments, the technology, it's the way, so if you look at an optimized attachment and then you have an aligner on it, there's a little space between the bubble where the aligner is and the actual attachment. So the way the tooth moves, it's an actually force-driven mechanic. So the plastic pushes on the attachment, on the optimized attachment, and the tooth is supposed to move into that little space that's there. Whereas a conventional attachment is like, it's like a block, like a brick on the tooth, right? And then the plastic just grabs onto it and moves the tooth like this. So there's no space between a conventional attachment and optimized attachment. Whenever you don't remove attachments, when you do a scan for refinement, that optimized attachment essentially becomes a conventional attachment because you don't have that technology, that space that's in the part of the aligner and the tooth. So they found actually that the conventional attachments work better than optimized attachments. A bigger horizontal, chunkier attachment just gives the plastic, and it just intuitively makes sense. It's giving the plastic more surface area to grab onto. So if you have more surface area, you're pushing on that lateral incisor to extrude it. So it just makes more sense. So if you go to lectures with Jonathan, because these Maz Mashiri, those are like the big Invisalign speakers, they don't even use optimized attachments. But then there are other Invisalign speakers that one is my mentor. She only uses optimized attachments. So there's no clear, like everyone has their own recipe when it comes to Invisalign, and I don't think one way is right, the other is wrong. My experience, the longer I'm in practice, the more Invisalign cases I do, the more I realize optimized attachments don't work as well. Okay, that's just, it's one of the ways that Invisalign has differentiated themselves from other clear aligners is that the optimized attachment technology. How effective is it really? I don't know. That's to be determined, right? So that's what this one study found. It just came out in 2023. Yes?
So for horizontal type, for the extrusion, you use the beveled one.
Guess what? This study actually used, I guess I didn't write that there. So 3 types. All 3 types were equally effective in extruding the incisor. It doesn't matter where the bevel is. If it's bevel gingival, bevel incisal, or no bevel, it's fine. It works the same.
So just like random.
Just put a brick on the tooth, yeah. Put a brick on there.
People don't want attachment on that tooth.
I know, but guess what? Realistic expectations right off the bat. And then a lot of times you you didn't want attachment, so I couldn't fully rotate your tooth. Well, can you we talked about that. I can't fix your tooth without that attachment. So if somebody is putting up that much resistance, then we shouldn't be treating them. Yeah. Go ahead.
Quick question about conventional attachments. Since it's fully engaged in the tray.
Yeah.
When patients remove the aligners and put it in, does it wear and tear more easily than the optimized, or not really?
Great question. I've actually wondered about that. So I don't know if you could visually see it, but then I often, when I put these conventional attachments on and I take their occlusion, if they're biting on it, I just trim them a little bit. Is it making it less effective? I don't think so. Because there's still tons of other surfaces to bind to,
For very long aligner cases, more complex cases,
Yeah.
do you ever find yourself having to re-add attachments at a later stage just to make
Yeah,
the shape?
all the time. I just replace them. Like if I have an optimized, a dinky little attachment on there that's not doing what I want it to do, I just put a huge conventional attachment on there, and then it works.
Okay. So when you do the refinement,
Yeah.
you change it out.
But now what I do is I don't change out all my attachments. I leave a lot of them on, a lot of my conventionals on. So it's just more efficient, and I think it just the aligners even fit better sometimes. It just if a tooth doesn't need a huge amount of movement, or if I'm using it for anchorage, let's say I have a rotated lower lateral incisor, and I want to rotate just that one tooth in my additional aligners, and I have 2 good size, chunky conventional attachments on my canine and my central incisor, I'm not going to replace those because I'm just using them as anchorage, and then maybe I will put a new one on that one lateral incisor that I'm trying to rotate. Yeah, so by the way, please ask questions anytime you want. You just raise your hand, interrupt me. It's all good. Okay, so this is an example of poor case selection, okay? So this is somebody who came to me. They were treated by their dentist, and she goes, my bite was off, and my dentist did Invisalign for me, and now my bite's even worse. So it was Express 7. There we go. This is the bite. What's wrong with this? I mean, let's watch it again. Do you think, I mean, at least they have good attachments on there, which is good. But then is this going to happen with 7 aligners? I mean, it's like, you'd have to be a magician to make this happen with 7 aligners. I think there was a good deal on Express 7 at the time there was a promo. So what are we trying to do for this patient? Like, I mean, like, you know, she had told her that your bite's just going to be a little bit better. It's not going to be perfect, but it's going to be a little bit better. This is a situation where you cannot do a little bit better. This is an all or none. You go all the whole way or you don't touch, right? Like, and this, I can't treat this with Invisalign. Like, no matter, even if I have 60 aligners, if I have 90 aligners and elastics all day, every day, I cannot fix this with Invisalign, okay? Mike may agree. Some Invisalign providers may, I mean, you may disagree. Some people may disagree with that statement. But it really depends on, like, what is the problem? Let's identify the problem. So she wore an interesting night guard and caused this to happen. She had braces in the past. The reason the dentist didn't want to, this tooth at number 7 is gray is because it has a very, very, very short root. So she didn't want to move it. So now let me ask you a question, you guys. So that tooth, even though you're not moving it, if you're putting attachments on all the other teeth, like, there are forces on that tooth, you know? Like, so if you have to move it, might as well move it. So it has a short root. We move teeth with short roots all the time. Like, what's the big deal, you know? Like, it's not going to get more resorption necessarily. So you tell the patient, you know, your tooth might get more resorption, but I have to, like, if you have to move a tooth, just move it, or don't treat the patient, you know? So this is the last clean check I did for her. So I ended up treating her for 24 months. I put braces on the lower arch, and then I did Invisalign on the upper, and then I finished her with Invisalign. So she was in lower braces for like almost a year, and I will show you why this worked. And so she wore classics, and the bite fully closed. Now, is it going to relapse? Maybe. These are really hard cases. Posterior open bite cases are very, very difficult. But the reason braces worked is right here, is torque. Torque on the second molars is very, very difficult to achieve with Invisalign. It's a terminal tooth. Anytime you have a terminal tooth with torque problem, you cannot get that with Invisalign, no matter what level provider you are and, you know, how many attachments you have. It's just really hard to get. So that is something braces got for me in 10 months. Braces on the lower arch. But you know what? It actually worked. Invisalign on the upper, on tooth number 2, it worked really well. Look at how that curve of Wilson's corrected. That I had an attachment on the buccal, a really good size attachment, and she was a good patient, so it tucked it in. But this is the reason for open bite, and this is why we cannot correct the open bite with just Invisalign, in my opinion. It's all my opinion, right? Okay, so let's talk about general tips. So you want to exaggerate your rotational corrections. So at the end, even you don't want to finish your clean check perfect. If you have a lateral incisor that needs to turn mesial in, turn it mesial in by another 3 degrees, 3 more clicks to have it go in, okay, at the end. Always build those in, always. If you have like you have your 8 and 9, one's like a little bit forward than the other, finish your clean check with 3 clicks in, over correction, 3 clicks, okay? You know what I mean by 3 clicks? No. Okay, so there's the clean check. You grab the teeth, and there are different ways of moving the teeth. You could do like in and out. You could do tip him, angulation, and then you could torque them, like root movement. So you grab the mouse, and you click on the movement that you want, and you just go click, 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 click. And it just goes boom, boom, boom.
Each one has a different amount. So it's a little tricky. You need to be comfortable with live clean check.
Live update, no. The tools, yes.
I usually don't do it myself.
Yeah, you just ask the technician. So
Or I
remember,
ask the doctor.
yeah. So,
She does it for me.
oh yeah. So rotational correction always needs to be exaggerated. Always. Finish with heavy posterior occlusion. Almost always. The reason I say almost is that if you have a big time kind of an open bite case, some people like to finish with no posterior contacts. Even my anterior open bite cases, I finish them with green posterior contacts. Everybody else gets red posterior contacts. All my ClinChecks get red posterior. I cannot tell you last time I saw a posterior open bite with Invisalign. It just doesn't happen because you really exaggerate it in the ClinCheck. But I don't mean like make the teeth go through each other. You just want to see red contacts. Sorry, does somebody have a question? Oh, Mike? No. Okay, so wait, where were we? Okay, so then do not overexpand your molars. This is how you get posterior open bite. Because what's happening when you expand, look at your ClinCheck. The first thing I look at when I get a ClinCheck back from the technician, I look at the transverse. Look at your arch form. That should be the number one. Are they blowing out the arch? They do that all the time. And then by the way, you can go back and look at your clinical preferences. You can limit posterior expansion. The first thing you should do if you're seriously considering doing more Invisalign cases, go and look at your clinical preferences and set them the way you want them, because your ClinChecks come back a lot better initially. So like posterior expansion, I limit it to 3 millimeters. I don't want more than 3. You can expand more in the premolars. The farther back in the arch you go, the less expansion you should get. A lot of times the arch form on the second molars looks good. Let the second molars dictate your arch form. Don't blow out your second molars, because that's how you'll get posterior open bite, 100%. Okay, you're going to get that case that I showed with the torque problem of the second molars. Okay, so you want to utilize virtual bite rams the right way. They're very, very helpful. I think it's like the greatest invention Align has had. Is those virtual bite rams, and I'll show you what those are. So attachments, use them for posterior anchorage, and use them for root control and rotational control, and then utilize IPR appropriately, and utilize elastics when needed. So undesirable side effects, so poor tracking, we all know they don't track. Part of it is inherently Invisalign's just not that good at it, honestly, so we have to build in these additional features. And then you can have anterior occlusal interference. That is so easy to get with Invisalign. Oh, my teeth are straight, but my front teeth are hitting. Always, right? That's just the number one problem. So I'll show you how to avoid that, because now I've gotten smarter at that, and I just build that into my ClinCheck, and I don't let it happen. Because once that happens, it kind of I feel like it kind of makes the patient lose trust in you a little bit, because it's uncomfortable. It's just it feels off. It just feels off when that happens. Posterior open bite, that's another side effect. And then open interproximal contacts. Oh my gosh, that's the first thing that happens. I tell my patients, first thing you'll notice with Invisalign, your floss is just going to go right through everywhere. You're going to get food caught in there. So floss just goes in so easily, just because the aligners, same thing happens with braces actually. They're expanding the arch, they're moving teeth. I also think there's some of it is the wedging effect of the plastic itself. The plastic is so adapted well into the embrasures, and it just pushes between the teeth and opens a little bit it lightens the contact. That's my theory. I don't know if that's been proven, but I think some of it is the wedging effect of the plastic. That's why I get calls from dentists, oh, the contacts are open. Wow, it's just what happens. I'm going to tighten them at the end, but this happens every time. So price of straight teeth, you'll have food get caught everywhere, and then you'll have black triangles. Doesn't sound very appealing, does it? Yes?
So are you saying for the open contacts that you're essentially usually doing refinements to tighten them?
Yes.
Okay.
Every time, without exception, unfortunately. And if you aren't doing it, it's because you're not catching them. And the reason you're not catching them is you're not flossing them. If you floss everybody at that debond check, that when they're almost at the end, I guarantee you'll find open contact somewhere, at least one.
So essentially, every case of yours has a refinement stage to it.
Every case of mine has a refinement, so we'll talk about that too. I'm a true believer in refinement. I think this idea of, oh, no refinement, the really guys that are really good at it, they don't do refinements. I think that's bull. I'm sorry. I don't think that's possible. It's just not possible unless you're not giving your patient the best outcome. If you don't want to give the patient the best outcome, then don't do refinements. But refinements are it's just part of this process. And I'll talk a little bit more about that. Okay, so we talked about, so gingival recession, that's another big one. So utilize IPR appropriately. Let's talk about IPR. So we're doing okay on time? Okay, so IPR. So do not over-prescribe your IPR. And I'll show you what I mean by that. So I would say, and then do not overperform. If you're prescribing 0.3, do 0.2. I don't do those little gauges. I've never used them. They're completely pointless. So there is some error inherently built into the plastic, okay? The plastic cannot detect 0.1. And since we talked about the plastic open space between the teeth, opens the contacts, then you should always do less IPR than what you see on there. What I do is and I don't use disc anymore. I think discs, they do a disservice to the patient. I think you really ruin the contour, that contour of that contact, just like you flatten it out with air rotary disc instrument, that disking. So I only manually do it, which I don't know, I think I might get arthritis in the next couple of years. It's a lot of work, but I really think that's how it should be done. And you don't need much. So I just take that diamond grit strip and I just go just a little bit until floss goes in easily. That's my IPR. That's my standard for IPR. I may do some more at the refinement stage, but I just don't do all of it, Okay, so, and then you use it to manage black triangles, and then I do a lot of fake IPR. And my assistants now know what that means. Fake IPR, so you guys all know virtual C-chains at the end to close those those open contacts. Instead of virtual C-chains, because I don't like virtual C-chains, I put an IPR in the prescription. I don't do it in the mouth. That closes the contact, okay? So that's fake IPR. So if it's in the posterior, like somebody comes in and they have an open contact mesial to number 19, and I run floss, then I put in 0.2 in my ClinCheck, and I don't do it in the mouth, and that tightens that up. The reason that's better than a virtual C-chain is that virtual C-chain is taking everything and going, tightening everything, whereas this is just focused in one spot. And then on the anterior, on the incisors, I put in 0.1 fake IPR. And when my assistants see 0.1, they know it's fake IPR. They know I'm not going to do it. So the 0.1, if you're wondering how you could get 0.1, go to your settings on your ClinCheck and click on, there's that setting wheel, click on it, and then click on Allow Non-Recommended IPR. You have to do that, otherwise the default doesn't allow you to do 0.1. And then I just take right across all the anterior teeth, and I just go click, click, 0.1, 0.1, 0.1, 0.1, just because I want to tighten it. And I do that in the refinement. So that's how I tighten the anterior contacts in refinement, okay? So then tooth-size discrepancy, if you have mandibular access, which I guarantee most patients have mandibular access. What that means is that if you take the tooth mass, the sizes of their lower canine to canine, and you add them up, and you take the upper canine widths and you add them up, there's mandibular access. And it's usually because 7 and 10 are a little undersized. Okay, so that situation, if they're little class 2, if they have a little overjet, that's okay. You're not going to run into problems. But if they're little class 3 or solid class 1, you're going to get anterior interferences when you line up the lower incisor. So that's when you have to IPR the lower, or you have to open space on the upper, one or the other, or sometimes both. Now I do both. Okay, so only do it in this case. Do not do IPR just because someone's crowded. This is how I used to think. I used to think, oh, they're crowded, and in order to get the teeth to slide next to each other to reduce the friction, I need to IPR. Wrong. That is the wrong mentality. That is not how aligners work, and I'll show you why. So when you do, so this is an example of black triangle management. This patient, all she had was I did IPR well, she had Invisalign, and we aligned everything. But those 8 and 9 are actually her natural teeth, and then she got veneers on 7 and 10. So all I did was I IPR'd with hand strips, couple different visits, maybe 1 or 2 refinements. I just kept IPRing a little more, and it closed it really, really nicely. And then she got veneers on 7 and 10. Looks very natural. So I think I really don't like the look of black triangle between 8 and 9. It's just so ugly. I mean, it's like, right? Like you can just do a huge service to somebody. They have to have kind of those triangular shaped teeth. Okay, those triangular shaped teeth are ideal for IPR. Somebody has square shaped teeth, if the contact point's already long, you can't make it longer. So that's what I tell people. I say, I'm not gonna file the whole side of your tooth. I'm only gonna file where they touch. And I'm just gonna make that contact point longer. That's all we're doing, you know, and there's plenty of enamel there. There's no harm to the teeth whatsoever. Okay, so this is what her smile looked like. Huge difference. Just IPR on 8 and 9 and veneers on 7 and 10. So let's talk about IPR. When you prescribe IPR, what are you actually doing? Think about the plastic. What is the plastic doing? You're putting a power chain on the teeth. You all know what power chains is, but we use with braces all the time. You're taking the arch and you're squishing it. So with braces, the only time we put a power chain on is after the teeth are straight. And the reason for that, because if you put a power chain on a light wire where you still don't have alignment, where your teeth are still crooked, and you put a power chain, you're not gonna let them align. They're just gonna, the power chain's gonna overpower your wire. It's like pretty basic, right? But why do we put so much IPR in Invisalign? That's actually the reason, one of the reasons our cases don't track. So this is like, in the past year or so, actually like a couple of years, I feel like I've had an epiphany in Invisalign. So my cases track so much better. And here's something I want to tell you guys. Whoever designed and invented Invisalign, and these people that I like show you the ClinCheck itself is not how teeth move. And they're now figuring it out, and they have now this thing called IPP, individualized personal. Have you done your IPP, Mike? Yeah. So they figured out that their system, you know, their tracking, it's like the way they move is not how the teeth move. And they're now getting better at it, okay? So take that ClinCheck with a grain of salt, okay? So why is it that we don't IPR with braces and they still line up? Teeth don't know if they have braces on them or if they have Invisalign. Why should it make a difference to teeth, right? So we put braces on, they all line up, they get straight, and then at the end, if we want to, IPR for tooth-size discrepancy or for reducing protrusion, then we IPR once they're straight. We should do the same thing in Invisalign. I absolutely believe that. Yes?
You mentioned IPP. What is that?
So it's individualized personal plan or something. So Invisalign, I actually don't know if it's available to GPs. It's basically you tell Align your recipe, how you like to do things, and then they develop an algorithm that all your ClinChecks come back with that algorithm.
So it's different than the preferences that you said?
Yes, it's different.
Okay.
I don't think it's available to GP.
Yeah, it's probably not, right. So yeah, they figured out that there's room for improvement, right? Okay, so again, align the teeth prior to retract them. When you build in IPR into your ClinCheck, you're telling the teeth to squish together. You're telling the plastic to squish. You shouldn't do that if the teeth aren't aligned, okay? So again, I only perform it in those cases, not for alleviation of crowding, okay? So this is an example of poor planning. This is a case I did. So this is what I'm saying not to do. Look, what's happening here? They're retracting and aligning at the same time. That's not biologically what happens. It's not how it happens. You see this all the time with ClinCheck. Look at that number 25. Rotating and retracting. And I did this because I wanted to avoid protrusion because she had very thin attached gingiva, and I just didn't want to like cause a recession, which also was wrong way of thinking. But anyway, okay, let's move on to the next slide. Okay, so look at that. Whoop. So that number 25. No, wait, is it 25? I should think about my G. 23, 24, yeah, 25. It still rotated. It didn't track after 14 aligners. So now I'm telling her, okay, we did Invisalign Lite for you, and we have like more aligners to go, and like I'm not going to charge you, of course. And then she goes, how many am I going to have? 8 more aligners. 8 more aligners? I've already done 14. Like it's like such a shock to some people, right? And I'm like, she goes, well, that's a few to you, but that's a lot to me because I've already done 14 aligners. And I have to explain, oh, well, with braces, when you're in the detailing phase, that takes longer. When you first put the first wires in, then their teeth are straight in like 8 weeks, but then you spend 6 months detailing, the final movements are harder to achieve. That's how I explain to them, like when they're shocked at like, why do I have so many aligners in my refinement? Anyway, but that's why that tooth didn't track. It's because I prescribed IPR, retracted them before that tooth was derotated, okay? So how do we avoid posterior open bite? You need to identify tooth size discrepancy. If they have small maxillary laterals and they have a crowded mandibular arch and they're solid class 1 or they're class 3-ish, you have a tooth size discrepancy. Like you're going to run into an anterior interference or posterior open bite, and usually both. So you need to stage. So this is what I do now a lot. It scares people. Like one of my instructors, faculty at UCSF, I was working with her clinch, and I said, open spaces distal to 7 and 10. She was so uncomfortable with it. It makes us so uncomfortable. When our patient sees this gap between their teeth, they hate it. Like they think you're doing something wrong. But this is what I tell my patients now in those cases. I'm going to open spaces behind your laterals, and then we can close them later. I guarantee you, if you do this, you're not going to see posterior open bite, because when you open the spaces, your front teeth kind of like, they just fit better. Like they need to advance, their incisors advance as the lower lines up. And this happens with braces all the time. You put braces on somebody and they come back, like, oh, why does my daughter have a gap between her front teeth? Well, that's actually because the teeth are fitting better. The reason lowers were so crowded is that you have a tooth size discrepancy, and you need to tell them that beforehand. If you're going to IPR open spaces, you got to tell them before that. But I can't tell you how much this has saved me. So anyway, and then you stage this is like, so I open, they're called also Iowa spaces. I guess there was an orthodontist at the University of Iowa that came up with these spaces. So very, very helpful, especially in your class 3 cases. Your class 3 cases, we need to open spaces 7 and 10. Okay, so then you finish the treatment plan with heavy posterior occlusion. You exaggerate curve of Wilson correction. This is huge. That case that I showed you with the 7s like this, build in click, 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 5 clicks of buccal root torque on your ClinCheck. Do you know what I mean by that? Like your upper second molars, take your mouse and build in that extra buccal root torque and just tucks the crowns in, and you avoid posterior open bite. So very, very important. Okay. So how do you avoid periodontal attachment loss? Do you guys know tooth movement table? Mm-hmm. I now spend a lot of time on tooth movement table, and I'll show you why. So we're all taught that tipping is bad. Like, isn't that kind of weird? Oh, Invisalign can only tip teeth and cannot move roots. First of all, that's totally not true. Invisalign can move roots just fine. But we actually want to tip teeth. That's how teeth move. So your lower incisors, when you're lining them up, tip them. Keep the roots lingual. You don't want to see if your ClinCheck comes back with your incisor going, root, root. Guess what's going to happen? You're not going to track, and you're going to get attachment loss. If you're lucky, you're just not going to track, but I've seen attachment loss. Okay, so, and as soon as you see poor tracking on any tooth, remove that attachment. Yeah, I've seen funky things happen when the attachment's on there and you're not removing it. Because a lot of times we see the patient who's like, oh, just use your chewies more and you can salvage that. And then, like, you don't want you don't want to tell the assistants, oh, you need to do a scan because they get annoyed. Now we have to do a refinement. Just take the attachment off at least, because bad things can happen. So here's a case, 18-year-old, pretty class 2 on the left side, solid class 1 on the right. His chief concern, of course, is that number 11. Deep bite, moderate overjet. So very narrow arches. You can see the shape of the lower arch form. So what we did was he was an excellent patient. We did distalization on the upper left, had him wear class 2 elastics. And then this is his progress. And then look at that, number 24, gingiva. It's like, that's when you're like, the patient comes in and you're like sweating and you see that. You're like, and your heart rate goes up. You're like, how did this happen? Why did this happen? And then, so the arch form looks great. Class 2 elastic wear has been great. But then there's that number 24, and then I'll show you why that happened. So this is, the upper one is the before, the lower is progress. You can clearly see the curve of speed has leveled very nicely. So we've got really good mechanics to reduce the overbite, but then we have that attachment loss on that tooth. And then now, let's look at how I built that. Look at your lower central incisors. What's happening there? They're intruding, but they're not proclining. That's a problem. If you see this, you'll see this all the time on your clinch checks. They will intrude the lower incisors, but they will not procline them. This is not how teeth move in braces. Teeth move with braces, and especially class 2 elastics. When you run class 2 elastics, your lower incisors go forward. That's not a bad thing. That's just biology. Why are we trying to avoid that? If you avoid that, then you get gingival recession, which is what happened in this case. So build in extra lingual root torque on your lower incisors, especially when you're correcting deep bite like this. So if then I went back, and because I never used to look at the tooth movement table, then I went back and looked at it. Look at that where it's circled. Lower right one, lower right left one. So 24 and 25. The roots are going buccal by like a teeny bit, but guess what? That was enough that as they intruded, that caused recession. So I will never make this mistake again because I learned from this mistake. There's nobody to tell me that this could happen, even though I went to orthodontic school. Nobody told me this. Because Invisalign, this whole clear aligner treatment is relatively new. And even when I went to school, my instructors didn't even know things like this could happen. Yeah.
If you brought that to back lingually, do you think you can regain some of that?
And we did, and we got the attachment back, mostly, yeah. So, I mean, he's a super nice guy, and I looked at him and was like, oh yeah, we've gotten a little bit of recession on your, but we're gonna fix it, it's okay. So, so of course, this is called a double diamond attachment. This is Jonathan Nicozis's attachment. Honestly, it doesn't matter what attachment you have on there. Like, just put an attachment. Like, put something with that flat surface on top. Put a chunky horizontal attachment, and then that's key. You see lower left one, 2.8 millimeter lingual root movement. That's a huge amount. Like, it's like almost 3 millimeters of moving, but you need to build that in to make that work. So then, yeah, like recovered. It's not perfect. And he did tooth whitening. I mean, he's super happy. He's finished pretty nice. But even when I see him for retainer check, I'm like, I did that. I caused that, right? But it got a lot better. And to answer your question, I see that happen all the time. You recover. You regenerate tissue. So.
I have seen that happen too in a couple of lower tiers. So now based on how their teeth are and the gums are,
yeah.
Some people have really narrow, like anterior mandible. So you anticipate that, and based on that, you add a lingual torque.
There you go. You already know that. Exactly. Some people just have a very thin biotype, we call it, very thin attachment.
If they are super prominent,
Yeah.
and if they are like rotating
Yeah.
and retracting, you want to add lingual torque to the root.
That's right.
So that it doesn't look that prominent.
Exactly. See, this is stuff that no instructor taught me. I just learned it on my own. Okay, so here we go. Attachments, put them almost on every tooth. You're gonna tell people, the 13-year-old that comes into your office that wants Invisalign, I don't want braces. Well, guess what? You're gonna get attachments on every tooth. I'm gonna lay it out there. You make the decision, because I don't want to mess around. I don't want you being treatment for like 5 years and still not track. So, I tell them attachments are like brackets. They're brackets. They're anchors for the plastic. The plastic is your wire. Braces, aligners, not that different. I mean, in our minds, I think Align Tech has done a very, very good job at making us think they're very different and making us think braces are on the dark side and aligners are on the good side. Yeah. Again, no one's ever told me this on any Align meeting either. I've figured this out on my own. Because everyone's motivated financially, I think. Unfortunately. This is a study club, so we can talk about stuff like this, right? So really, no, they're not that different. Teeth don't know what's moving them. You want the patients in your office because they want results. It's not that they want Invisalign. Invisalign is just a product. Orthodontic treatment is what we're giving them. We're not giving them Invisalign. We're giving them orthodontic treatment. And it's so easy to lose sight of that. And I did. I was one of those people. And I feel differently now. Anyway, so I use conventional attachments wherever I have a difficult movement. I don't trust those optimized. I may be proven wrong in the future, but I don't know. Horizontal attachments for vertical movements, up and down movements. Vertical 4 millimeter, that huge vertical 4 millimeter attachment for your tip, for your root angulation. Always expect additional aligners. The more I'm in treatment, honestly, the less I do light. I don't do express at all anymore. The less I do light cases. Just like, why am I doing light cases? Like, I question myself. And then I have to come back to the patient and say, oh, you owe me $350 more because we now have to do a second refinement. Like, that's not a practice builder. People don't like to hear that. Just charge them the full price and take it or leave it. It's like, I don't know, I just feel like, I still do light cases, but honestly, I feel like those light cases are my least favorite cases. And almost like every single one, I've ended up ordering a third refinement. You guys know what I'm talking about.
Also, often it makes sense to just use the moderate and comprehensive. For us, it's because we don't do that many cases, it's
right.
Still a significant financial.
It's a huge financial difference between, yeah. So for me, I mean, I have the discount, so it's like, it's kind of a wash. So anyway, I just try not to. So everybody needs refinements. When we're almost done with braces and they come in at the end, and we do, every 6 weeks, we do detailing. We're detailing, like we're tweaking a tooth. Think of refinement as a detail appointment. Literally, that's what it is. It's like, okay, well, your tooth didn't fully get there, even though I had all that overcorrection, everything built in. We want to get it there. We want to give you the service that we promised you, the results that we promised you, and yeah, we're going to do refinement, no problem. Scan, 10-second scan. Okay, and then the fake IPR, we talked about it. If something's not tracking, don't do the same thing. Super important. I've been guilty of it too. If something's not tracking, change something. If you have a difficult rotation, maybe open a little bit of space around the tooth. It will work. Click, 0.3 millimeter, 0.5 millimeter space, open, and then your rotation. Put a good size vertical or horizontal attachment on there, and it'll work. So don't do the same thing over and over if it's not working. Okay, so think biomechanics and not aligners. Like I told you, I lost sight of this too. I thought aligners for too long. Focus on tipping the crowns. Open spaces while you're aligning the teeth, just like braces do. Know what's synergistic and what's antagonistic. So perform those movements in stages. So like, if I'm trying to procline and intrude, I don't want to do it at the same time. I tell the technician, procline the lower incisors first, then intrude them. And I tell them by how much. Procline it by 10 degrees and then intrude them. So you separate those movements and it gives you a lot more aligners, but that's when it works. Other than that, I don't change the staging. If you keep the same, so we used to tell the technicians, we used to say, oh, double the number of aligners. Complete waste, you guys. There's no point in doubling your aligners because the movements are the same. You're just slowing down the movements. What you want to ask them is the staging, procline first, then intrude. Or open space first, then at the end close, like those Iowa spaces that we talked about. So that's how you get efficient treatment. Just if you keep the staging the same and you double the number of aligners, you're just putting more plastic in our water. Think of it that way. Do you know every time they suck down this plastic on this resin, do you know that goes in earth? Like, that, where does that go? You heard of the Invisalign expander, their new expander? 38 pieces of plastic that's this thick versus a beautiful metal RPE that I can put in. Like, where does that plastic go? So think about it. When you're doing these things, think about what you're actually doing. You know, not just like, you know, I think about it a lot more than I used to. Okay, so here we have, they have to wear 20 hours a day. That's just, sorry, teeth move best by light continuous forces. Light continuous forces, remember that. This can be heavy intermittent with Invisalign. If you're putting it in, like, ow, my tooth hurts, and then you don't leave it out for 8 hours, and then you put it back in, oh, my tooth hurts again. Is that really working? Is that optimum what teeth want to do? No, it's not good. So they have to wear 20 hours a day. If you pick the right case and your patient's wearing aligners and teeth are not tracking, there's something wrong with your treatment plan. Don't always blame the patient. I used to do that too. Oh, they're just not wearing it. Oh, they're just not wearing it. No, like your treatment plan's not right. You know, like they're wearing it. I see that in my case. I pay more attention to that. Go back and study your cases. You know, look at a tooth that, like premolar that was rotated and you put an attachment on it. Go back and see what that tooth did. You know? Okay, anyway. So case review, we're gonna do a couple of case reviews. What time are we done?
10:30.
8:30, is that 20 minutes? Okay,
I have a quick question.
yes,
For the open bi posterior cases that you mentioned,
yeah.
if the patient asks for S6 retainers or clear retainers that comes with Invisalign,
Yeah.
are you ever concerned about the material of the retainer opening up the posterior bite?
Yes, yes.
So do you always go with poly retainers then?
No. So what I do, I've gone back and I've put buttons on their molars and had them wear elastics with their Vivera retainers at night.
Indefinitely?
Like for 6 months, and they come back, and then it's usually stable. Those are really hard cases, but you know what? A Holly's probably a better option. I just don't consider giving my adults Holly retainers because they don't like them. I don't want a Holly in my mouth. The kiddos, I love Hollies, you know. So, but yeah, adults, I don't. Oh, you know why? Actually, Mike, I just realized something. A big part of it is also that the transverse, like the expansion. So you know, sometimes you could cut the plastic off and have them wear rubber bands. Like I want plastic on those teeth because I want them held in place. I don't want the because a lot of the posterior open bite problems is a transverse problem. So I don't know, maybe Holly holds that better. I mean, holds the transverse better, I don't know.
One more question.
Yeah, sure.
Regarding the posterior open bite cases,
Yeah.
you mentioned the second molars is the issue
Yeah.
a lot of times. Also, a lot of times my second molars are not contacting correctly.
Yeah.
The palatal cusp, they don't wear the same as
Yeah.
other teeth.
Yeah,
Do you ever find yourself in a situation where you have to do enamelplasty?
I never do that.
Okay.
Because I've had patients that come to me that were terrified that had an orthodontist do that to them, and they're just like, it was very traumatizing, so I don't do that. Yeah, but I know people that do that. I don't want to touch someone's tooth like that and then have them have a question mark in their head for the rest, forever, you know, just, yeah. But that will work. Or what works better is just overcorrect your curve of Wilson, give it more buccal root torque, and it will lift up the palatal cusp, you know. So that works. Because we don't really have to shave down that palatal cusp in braces cases, right? Do you ever?
No.
Why is that? Right, why do we have to shave it down in Invisalign cases? So are we giving a subpar service to our patients, and then we compensate by shaving their tooth? something to ask, right? Okay, so this is like kind of like, is it AC on in here? Sorry. This is kind of a typical patient that comes in, right? 48-year-old female, wants to have her teeth straightened before her 50th. Wonderful, wonderful lady, high dental anxiety, moderate mandibular anterior crowding. So the first thing I look at is look at arch form. Look at arch form when you look at your patient, and look at arch form when you look at your ClinChecks. So the problem, when she was 8 years old, I would have put an expander in her if I had seen her at age 8. That's the first thing I would have done. Put a palatal expander, get the first molars out of crossbite. So the reason Invisalign worked, so her concern is the lower crowding, right? But am I going to tell her, oh, I'm going to fix that and leave your crossbite the way it is? Absolutely not. Because I'm going to go all or none. Because I know I can fix that crossbite. But I tell her, I'm going to correct your crowding, but I'm also going to fix your crossbite, so I need you to wear rubber bands. You're going to have attachments on every single tooth. So it's like take it or leave it. Like I can't pick and choose. If I don't, the reason I have to correct the crossbite is that I have to address arch form. If you look at that lower right, you're looking at number 30, it's too far buccal. I cannot not straighten that and then straighten everything else. It just doesn't work, unfortunately. So, so this is her panel. She looks pretty good. Good bone levels. So this is like progress a few months into it. Her name's there anyway. So it's, I had her wear cross elastic there. It's not there yet. You can see number 30 moved lingually quite a bit. Lower alignment looks better, but it's not there yet. So this is her finish. So we just kind of broadened the arch form. I would have liked to do more expansion on the upper, but I think part of it is if we did at age 8, we could have expanded more. So she had 60 aligners. We fully corrected the crossbite, and she finished in 16 months. So I promised her, and we finished her by her birthday. So, this is not overly complicated case, but it's kind of like a typical case. It's never as simple as a couple of crooked teeth. There's always something else going on.
You got improvement on your recession on the previous.
I know, I noticed that too. Lingual root torque, that's right. And the reason I was successful in this case is she already had good, healthy periodontium, good, thick buccal gingiva. You see this a lot. When first molars and crossbite, they have really thick gingiva there because it's an arch form problem. You need to move that tooth buccally. But then I also built in quite a bit of buccal root torque to compensate. So that's why they fit pretty well. Otherwise, I would have gotten the molar go like that, and then I would have gotten kind of an open bite. You see that a lot. When we crack posterior crossbite, like on a single molar, the finish never looks that good because a tooth has excessive curvature of Wilson. It has too much lingual palatal root torque. You need to give it buccal root torque. So you really need to exaggerate that on there. This is her after panel. Very long roots. She looks really good. So this is a class 1 severe crowding. This is an older lady. The reason I want to show you this case is that don't be afraid of gingival recession. I used to be afraid of it. I used to tell them, oh, I can't treat you. I'm not afraid of it anymore. Because I know how to move those roots. So are they going to come forward? Yeah, sure. But I need to control which ones are going to come forward. This is kind of the nice thing about Invisalign. You have control on every single tooth, and you can really spend time on your ClinCheck and move every tooth individually. It's pretty cool. So her concern was mandibular crowding. Again, look at that arch form. It's like lingually tipped in mandibular molars, pretty severe crowding and gingival recession. So some people would look at this and be like, oh, I'm going to take out a lower incisor. I absolutely do not. I never take out a lower incisor. I do not like that plan at all, basically for anybody. The only time I will do that is if somebody they have a lower central incisor that's just hopeless, and a dentist needs to take it out. Like, okay, I'll close that space, no problem. It's in in orthodontic school, that is one way of treating. If you have if you have a two-size discrepancy, if you have mandibular excess, you have small maxillary laterals, and you're pretty class 1, you can get away with it. But the reason I don't like lower incisor extraction is black triangles, because I don't like black triangles. And also the other problem with that, when you take out lower incisor, you narrow the mandibular intercanine width, so you lose your cuspid rise. You don't have cuspid occlusion because now your lower inner canine width is narrower and your upper is wider, so you just have too much buccal overjet on your canine. So anyway, I will basically never take out a lower incisor, even in severe crowding cases. So this one, she looks really good. Like I told her, I said, okay, you know what? Your gum recession, that tooth number 24, the gum is higher. This is what I tell them. I said, and at the end, we may worsen your recession, but what's going to happen is your gum line is just going to be more even. One of them that's high, the one that's high is going to be low, and then they're all going to just going to be more even. So, and that's what we did, and she's super, super happy. She's showing her lower teeth when smiling, because that's what they do when you take the final photo. They're like, because they want to show their straight teeth. And this is the wire that I use. I exclusively use this wire now. It's called a Memotane. We scan, we send it to AOA. That's a very well-known orthodontic lab, and it comes with a little jig. And I love that thing. I used to bend this wire on, take an impression, mold to pour up the model, mold the wire on the cast, and then put floss in there, and then just like taking that floss out with that scaler. It's just like, oh my gosh. So this thing is amazing. It's costly, but I charge for it. I tell them, well, you have an extra retainer, that's what we call it, and we tell them right up front. And if we know we're going to put one in at the end, we put it in the contract, so at the end they're not like, oh, I have to pay more now. And it's amazing, and like they can, these recession cases are great because they can push like little toothpicks and like little interproximal brushes under the wire because they have recession. They can water pick. It's easy for them to keep it clean. But yeah, even no matter how good you're at nighttime retainer wear, those teeth are going to relapse. They relapse in the day. They'll straighten at night when they wear the retainers. It's just like the only solution is fixed retention. It's not a bad thing. It's patient management. It might not be the best thing for if somebody cannot keep it clean and they get buildup, that's not a good thing. A lot of times I tell people, okay, I have to remove it, but it's our best thing. It's the best thing we have.
So that lingual retainer is only bonded on the canines?
No, every tooth. So this Memotane is actually, it's like so easy. We just do a scan. We do a pre-debond scan. We send it to AOA with iTero, and then it's got a 4-week turnaround time. There's no way you can rush it. 4 weeks later, they send us this really cute little model with a purple little jig, and then my assistants pumice and etch the lingual surfaces, and then I grab the jig, put it on there, and I put the jig here, and then I push my scaler right here. I push the scaler, flowable, cure, push it with scaler. If you don't push it with scaler, you may not fully seat it on the canine. Push it with scaler, flowable, cure, remove the jig, flowable, bond, then flowable on all 4. Yeah. It's just like lean and clean. Yeah, that's the way I like it. All right, so deep bite case. These are like the biggest restorative cases, right? Like the restorative dentist always wants us to open the bite, give them some overjet. This is a challenging case with Invisalign. This is, I would say, majority of our cases. Like a dull, kind of worn down front teeth, deep bite, teeny bit of lower crowding, but not a lot, right? They want to get veneers on their upper front teeth. Oh, my tooth keeps chipping. My dentist wants me to do ortho so they can fix it. Very, very standard, right? So then, this is my treatment plan. I want to show you what I've learned. So you have to have attachments on the upper anterior. Remember, incisor intrusion is a big problem for Invisalign. It's a big limitation. So, but what's the problem here? What did I not do? So I have a mix of optimized and conventional attachments. Is that a problem? I don't know. Honestly, I don't know. Maybe. But I just don't know. This is how you finish them. heavy posterior occlusion. I probably would have gone a little heavier at this point, like just more red marks. And then those are the upper anterior virtual bite ramps. They're very, very important for deep bite cases. This is how you avoid a posterior open bite. So this is, I wanted to show you what I did wrong here. So this is the ClinCheck. What's the problem here? We have really good curve of speed correction. Anybody tell me what the problem is?
You're doing two movements at the same time?
That's part of it. But what's the other problem? No attachments on the lower right lateral incisor. So what's going to happen here is, so that's what was prescribed on the left. That's what number 19 should have looked like. And that's actually what 19 looked like. Look at my curve of speed correction. Isn't nearly as good as it should have been. Why is that? Part of it is I didn't exaggerate. I didn't put in enough lingual root torque on my lower incisors. And then this is what happens. If you pay close attention to your cases, you see this all the time. You're intruding here, but you don't have an attachment on this tooth, and then suddenly your canine looks way taller than your lateral. So you need an attachment on that lateral incisor. You need distal root tip. So this is what I want to talk about, deep bite correction. Do you guys know what this wire is? We've seen this wire in ortho. It's called a curve of speed wire. It's my favorite wire. It does miracles. You have a deep bite case, you put it in, it has to be the right case. It doesn't work for everybody. And they come back, and then suddenly they're like 1 millimeter overbite 8 weeks later. It's amazing. So you want to simulate the same mechanics in your ClinCheck. So what that means, distal root tip on your mandibular, lateral incisors, and canines. Why do you need that? So think of it as this way. It's just like a curve of speed wire. Mandibular canines, if the roots are tipping distally, what are they going to do to the incisors? Push them down, right? If you don't have enough distal root tip on your canines, no matter how hard you try, you're not going to reduce your overbite. You're not going to intrude your incisors. So you need this movement, okay? So that is huge. So put a vertical 4 millimeter attachment on your mandibular canines and get that curve of speed effect. The other thing you want to do is you want to tip your second molars back, kind of a molar tip back, just like a curve of speed. So when I finish with red heavy occlusion, I kind of do, on my second molar, I want to tip it back and I intrude it a little bit. I go click, click down a little bit. It's because I want it to be green on the second molar, but I want it to be red on the first molar. Again, exactly like a curve of speed wire.
Distal tipping the crown or
Distal tipping the root.
second molar?
Oh, I'm sorry, distal tipping the crown. Yeah, mesial tipping the root. Exactly. So this is then I got smarter, and this is what I put in. So look at that. That's what you want to see. Distal root tip on the lateral, on the canine, and you have leveling of your curve of speed. I probably, if I were to do this again, I would have put in a little more lingual root torque on my lower incisors. Oh, where's her final? I just took her attachments off. Sorry, I don't have her final. But anyway, it worked. Take my word for it. Okay, so these are tips for deep bite correction. And we went over all of these already. So this is a 12, 13-year-old. This is another very typical class 3 case. Invisalign works beautifully for class 3 cases, just to let you know. So she, with the right ClinCheck, so she's clearly a skeletal class 3. But what we have going for us here is if you look at her upper incisors, they're pretty upright. They're like tipped back. So what does that tell us? We can afford to push them out. We can afford to procline the upper incisors. So, this is, so look, miraculously, the teeth go through each other. Does that work? Is that going to work, you guys, do you think? Does anybody think it's not going to work? It's actually going to work. The beauty of Invisalign is disclusion. It's like you're wearing a night guard, kind of. So you're not locked in. So Invisalign works beautifully for these cases. remarkably well. Look at my 1 millimeter space this to that lateral. I have to put that in. I'm sorry, there's no way. If you're gonna promise a parent, I can fix your class 3 and you don't have to have spaces, not true. It's complete false. You're never gonna fully correct it. You have to open that space. So, and then we could close it. We'll see, maybe we'll close it a little bit, but she might have like a sliver of space, nobody can see it. Or maybe she can get restorations. Nobody wants to get restorations, people hate that. So, but I tell them like, oh, it might be just like 0.5 millimeter, nobody can see it. We live with it, but I have to open the space to correct the bite. So those are bite ramps I have on the canines. I like putting them on the canines because in this case, she wasn't occluding on those. Her appearance said she was in full crossbite. So this is what she looks like in 9 months. It's pretty darn cool. Like she just wore the aligners very well, the rubber bands very well. So she looks great in 9 months. So then, yeah.
There was another presenter previously.
Yeah.
He would make the patient eat with the Invisalign.
Oh, okay.
Would you do that?
I don't. But maybe a couple years from now, I will. I don't know. But I don't know, would I want my kid to eat with her aligners? If I'm not gonna do something to my kid, why would I have it for my patient?
I've worked in another office that had people do that, and now I work in one that doesn't.
Yeah.
Their aligners would get really stained.
Oh, for sure. Yeah.
And so then that was like upsetting, and it's like if they take it off for 30 minutes, it's okay.
Yeah, absolutely. So even if you eat and you don't rinse your mouth and you put your aligners back in, they stain.
Yeah.
I mean, it's like, if you don't want something for your own kid, don't prescribe it for your patient. So those power ridges, I just don't really use them anymore. You know what their purpose is? Their purpose is to push the root lingually. Okay. This is progress still. She's not done yet. She's looking much better. These class 3 cases, you have to build in, you have to put in lingual root torque on lower incisors. Okay, so then this is, I want to see this one. More lingual root torque on lower incisors. This is where I'm closing this space a little bit, but I think I left some at the end. Oh, great. I was like, I hope I didn't fully close it. Don't fully close it. No, I didn't. Okay, good. Because you want to give a little bit of room for this patient to grow. Like, where are those incisors going to go if you finish with 1 millimeter over jet? Guess what? She's going to come back. She's going to go to another orthodontist 20 years later and have orthodontic surgery. So I'm not saying my 5.5 millimeter space saves her from orthodontic surgery, but it gives her a better chance. Okay, so don't be afraid of spaces. Educate your patients. Okay, this is how she finished. I think she finished really, really nice. And she has positive overdraft. So this is what I wanted to show you guys. So I think I did a wonderful job. I'm like, oh, I'm so good at what I do. And then you look at this panel, and what's wrong with that panel? Look at my lower lateral incisors. Did you catch the roots? They're mesially tipped. Why? Because I had power ridges, because Invisalign told me to put power ridges to tip the roots lingually, but I did not put enough distal root tip in my laterals. Huge. Every one of my cases now gets attachments on mandibular laterals, without exception, because I want distal root tip. Especially when you're leveling curve of speed, when you're intruding lower incisors, you need that. So yeah, that's a beautiful finish, but hey, I could have made those laterals better. Yeah.
In her case, was she a pseudo class 3?
She was actually. She was etched, and that's key. So what Mike's talking about is if you take the patient, tell them, okay, relax your jaw, let me close your teeth together. When she bites, she's actually edge to edge. If you tell somebody to bite, and if you tell them to relax, and they're still like biting like this, that's a surgical case. Do you know what I mean? Like, you take them, you're like, bite, and then they just don't go back. They have like 5 millimeter reverse overjet with no CRCO shift. And they have no crowding of the upper, everything's just so straight. They have this massive anterior crossbite. That's a surgical case.
Yeah, that's the case I sent to my friend that you're doing. Good thing I didn't do it.
Oh, yeah. Yeah.
Friend, we want to be friends.
I know. Treating friends and friends of my mother-in-law, those are like my worst patients. I'm sorry. Like they still call me and they find little things wrong with it, even like years after treatment. It's like, anyway, don't treat family members like that. So this is super sweet lady, very, very busy with her work. Like look at that lower lingual bar. Just stuff like this makes you scared of these lingual retainers, right? Like I can't tell you how many cases I've seen where the one root's completely out of bone, like with massive recession, and the other root's like completely lingual. These wires can become active. I don't know if this one's gotten active actually. Something funky's happened with this fixed lingual retainer, but really carefully look at those. And then an article came out actually recently in a JODO talking about like the potential harm of these fixed lingual retainers if your wire gets distorted. So all my patients, every patient that I put a fixed lingual retainer in, I give them a Vivara retainer to wear over it. Like, oh, wow, my dentist never, or previous, or no, you have to have this as backup and as a safety measure, yeah.
Just to reinforce your point, I also had a patient like that. Where, when she went to the hygienist for cleaning, the lingual retainer broke.
Yeah.
And the dentist said, not a big deal, let me just rebond that.
Oh, okay.
They rebonded it with it being active.
Yes.
And that patient ended up with severe recession of the inside.
Gosh, that's terrible.
So,
That's terrible. And you could salvage that some. You could torque, like we were talking about, torque that root in, but it's a disaster. So this is as hard as it gets, literally. Like I did, I wanted to, a little plug here. This QR code here, it's called iPro. It's free. If you're an Invisalign provider, you can do iPro. And you basically, you'll go through your cases with an Invisalign expert. I've learned so much from iPro. I mean, again, I have no financial interest in Invisalign, but I highly recommend it. A lot of things that I'm talking to you about, people told me in iPro, and I just like it didn't fully like sink in until I saw it with my own eyes. So this was the case I presented to iPro to help me. They basically walk you through every step of your ClinCheck. It's great. And then the doctor, the iPro doctor was like, and they're always in Costa Rica. And she's like, are you sure you want to do this in Invisalign? Like, what are you doing? Like, you're crazy. She literally told me that. And the next case I'll show you, she said the same thing. So, well, that's what she wants. She wants Invisalign. Okay, so again, look at arch form. Is there room for improvement? There's huge room for improvement. She has a V-shaped, narrow arch form. We can make things a lot better. We're not going to expand. So, and she also has all her wisdom teeth. That makes it so much harder. She would not get her wisdom teeth out. She was like, no way. So, this is I do not want to expand these. As a matter of fact, I'm not going to move the wisdom tooth. Maybe I did, I don't know, we'll see. But anyway, this one, I want to bring him in. I don't want to expand the second molars. That's the widest part of the arch. I don't want to widen that anymore. So arch form is huge. And then so what happens, the biggest challenge in this case is when we tuck that number 28 in, when we tuck it into the arch, it's going to procline the lower anterior even more, and it's going to worsen her open bite. So she's also got some chin advancement surgery in the past. Anyway, really nice lady, super, super hyperdivergent. So if you have this level of mandibular angle with this anterior open bite and wisdom teeth are present, this is like your biggest nightmare. Like you don't want to treat this case. But this, I'm showing you this because Invisalign is just so good at anterior open bite cases because Invisalign is good at posterior intrusion. That biting force where they clench all day and all night, that intrudes the molars a little bit. So it's good for that kind of movement, better than braces actually. Like this case, I couldn't have done it with braces as well as I did it with Invisalign. So I wanted to show you, so anyway, this is her treatment. We treatment implanted for 2 years of Invisalign. And so I have extrusion attachments on that side, extrusion on number 9, and then I put cutouts for elastics. You have to wear elastics to fix this. And then magically, it's like, boom, it closes. So nice. So see those? So they don't have posterior bite ramps. They don't exist. So what I do is I put those big attachments on the first molars, and then my assistants know not to fill them. So it becomes like a little cushion. So they bite on that, and that increases your posterior intrusion. This is her 5 months later. It's pretty darn good, right? And it's, again, we worked on the arch form. Arch form is huge. Just make sure you get your arch form right. Anyway. Okay, yeah, let's just skip anyway, this is how she finished. she finished in 10 months. She was like, I don't want to do this anymore. She's super busy. She complained every time she came in. So this is another thing I noticed. Some of those patients that complain and they want to be done are actually the best aligner wearers. And that's why they want to be done, because they've worn these aligners so dang well that they're just tired of them. So have you noticed that, Mike? They're just like, when am I going to be done? When am I going to be done? It's like, dude, just relax. Like, take a chill pill. Like, you'll be done when you're done. Like, and then it's only been 9 months. I told you 24 months, but she just wore them incredibly well. So, so this is what I want to talk about, smile line. So, some people would argue, do not extrude her upper incisors because you're going to make her more gummy. When it comes to smile aesthetics, what's more important, gumminess or smile line? Absolutely smile line, 100%. So I'm going to extrude her 7 to 10 all day long because I want her to have a smile line. She's gummy a little bit, so what? Gumminess is a youthful look. You can fix that though. Yeah, and then you could be excessively gummy, which is not attractive. But if you're a woman, you can afford a lot more gumminess than a man because it's a more feminine, youthful look. So I think that's a huge improvement to her smile. It's broadened the arch. It's given her a smile line, which she didn't have. Or that's a reverse smile line she had previously. It almost looks like something caused that, doesn't it? Like, how did that even happen? I don't know. Anyway. So this is like when I finished her and I had her stop wearing elastics, it bounced open just a little bit. There's an article about anterior open bites. There's always relapse on anterior open bite treatment. Whether it's surgical or orthodontic, there's always a little bit of relapse. So whenever you can overcorrect to do that, she wanted to be done with treatment, so we didn't do that. Everything looks good. There are the wisdom teeth sitting there nice and cozy.
Quick question.
Yeah.
With the wisdom teeth being so short, sometimes with the clinical crown,
Yeah.
do you ever have issues with Invisalign not seating well in that area? Or do you put attachments all the way on the wisdom teeth as well?
I never put attachments on wisdom teeth. Oh, like not seating, like bouncing?
Yeah.
Make sure you have attachments on your 7s.
Got it.
If you don't,
Yeah.
the aligner goes pop, pop, yeah. Anyway, this is a really fun case. She had orthodontic treatment. As a teenager, they did bilateral canine sub. Somehow the space is open. Maybe they didn't do a very good job for her. Maybe they didn't finish her well. Anyway, so now she has all these missing teeth. Extremely hyperdivergent. Look at this mandibular plane. I mean, this is like as steep as it gets. And a huge overjet. Like, how am I gonna, and then the periodontist wants me to open space for 7 and 10. How am I gonna open space without protruding 8 and 9 further? It's like almost impossible. Truth be told, we'll see when I'll show you the finish. Like, I don't think I would have been able to get as good a result as I did with Invisalign as I would have with braces. Like, Invisalign just was better at this case. Again, the hyperdivergent case. But also, she's incredibly well at wearing her aligners. So let's look at her case. She's also got this missing number 20, right? And a bunch of extract missing teeth. So this is her progress. We opened spaces for 7 and 10. And wore class 2 elastics. So I wanted to show you this because I want to show you how posterior distalization works, because this is where you get into the hard stuff. So look at that. You have to do that, and you have to run class 2 elastics. And then the really nice thing about these Invisalign missing teeth cases is, guess what? Now you can have a tooth. And we put this Pontic paint. We don't put Pontic paint in the posterior Pontics, but we put Pontic paint on the anterior Pontics. And this paint by Reliance that we just like, it's like a little resin you put into the aligner and then you cure it. And it's like one shade fits all kind of thing. So anyway, or maybe it comes in different shades. I don't know. We only order one shade. So anyway, this is a very, very difficult case. This is another iPro case. I showed to iPro. She was like, what are you doing? Like, don't treat this case with. I was like, oh, but I already promised her. She's already paid me. I got to do it. So anyway, this is her progress. Look at that arch form, beautiful arch form. Gotten really nice space. So you look at this, you're like, ooh, I have plenty of space. It looks beautiful. We did it. And then look at this. So she was a full step class 2. So we distalized that canine by what, like 8 millimeters? So this is incredible. Like, I'm showing you this because elastics work. Elastics are the best thing we have in orthodontic treatment, honestly. And I don't need it. So I used to put a carrier. You guys know what that distalizer bar is that you can put in with class 2 elastics? Yeah. I don't do that anymore. I just it's like class 2 elastics right off the bat, start distalization, that's what we do. And I tell them you're going to end up with gaps on the upper posterior molars, and then you can, anyway. So, but what's happened, we've gotten a lot more tipping than bodily movement. So anyway, we're going to skip this. So look at the root of number 6, though. So the tooth has tipped back, the crown is tipped back, the root is still in the implant site. Like I need to tip that root back. So this is her at progress. I haven't finished her case yet, but it kind of gives you an idea of what it would look like also when she's done, just like a nicer, broader smile. So I think doing this implant is like a better option for her than custom substitution in this case. And then this is the last case I'm going to show you, another very, very difficult case, like huge perio case, tons of problems, bilateral posterior crossbite, that very, very thin, this is that thin biotype panel, like very, very thin lower attached gingiva and anterior crossbite and perio problems. So first thing I'm going to do is I'm going to refer him to the periodontist. So the periodontist said, and I said, look, I need to extract a tooth from bottom, you tell me which one. And then I said, I'm going to extract the worst one. Like, I want, what's best for the patient. If it has to be a lower incisor, so be it. But something's got to go on the lower arches. Something on the lower right, preferably, needs to go. Because there's no way. Like, the lower incisor already tipped back. Where am I going to tip him to? Like, there's no bone there. Like, you have to take something out. So we extracted number 28. The periodontist told me that's got the poorest prognosis, perio-wise. It's got the crown to root ratio is like less than, it's unfavorable and everything. So we took that out. This is how he started. So this is a case where I'm gonna do combo treatment. I'm not gonna even dream about closing an extraction space with Invisalign. It's not an option in my mind. So I love combo cases. Actually, they're some of my most favorite cases. Because also I've learned to dissociate myself from thinking aligner or braces. And that, I think, that's when a light bulb went off in my head. It's orthodontic treatment. Use the tools that you have for the interest of the patient and educate them. It's not, I'm an Invisalign practice, I'm a braces practice. It's not like, I'm not trying to be something. I'm just trying to be a good orthodontist, right? And part of being a good orthodontist is educating my patient. Like, well, I'm going to take that tooth out. I'm going to give you a better bite and straight teeth, but I have to put braces on your lower teeth. And if you really educate them why that is, you'll sell it. They won't even question you. Like, sure, no problem. So this is like progress. This is the point. So if we're going to close this extraction space right where we're closing it, that 28, you're going to deepen that curve of speed. See the dips in like that? That's the biggest problem when you extract. So that deepening, braces are a lot better at controlling the Invisalign. And then you have to wear elastic. I put a button here. I had him wear a triangle to lift this side up. So again, this is when we removed the braces and we just, we decided to finish an Invisalign. And this is progress. Then in Invisalign, I have to have buttons. But he's pretty nicely socked in on that right side. Of course, I created black triangles, which I don't like. But you know what? This is how he finished. I think he finished really, really nice. Maybe a restorative would be an option. This is where my restorative colleagues can help me close those black triangles. Maybe BioClear, I don't know. But yeah, we fully corrected posterior crossbite. We were able to achieve positive anterior positive overjet for him, protected the periodontium, didn't kind of worsen the situation than it was. But yeah, main thing again is arch form. Look at your arch form. Look at, like, that's huge. Okay, so anyway, this is what I was talking about. Like for my phase ones, I always do Holly. All my full treatment adult patients, teenagers, they all get a Vivera. If I do a fixed lingual, I always give them a Vivera on top of it. And then it's worn 12 hours a night for the first year, and then they go to nighttime only. I may change that because, as a parent, like if I'm going to tell my kid wear 12 hours a night, like what is that, 7 p.m. to 7 a.m., it's just not super practical. I might just have them all go to just sleep time. The reason I don't want them wearing the retainers during the day is that they lose them. I don't want them taking them to school. So that's my protocol. Just wear them at night, what's practical, you know. And if their teeth are shifting during the day, it's because they started a lot of crowding, then they need a memo, they need a fixed lingual retainer, you know. So anyway. Again, this is everything I talked about. Clear aligners are just a tool. You're doing orthodontic treatment for the patient. Utilize your tools appropriately in the interest of your patient, so you can sleep better at night. Teeth don't move necessarily the way you see it on that treatment plan. They just don't. That's why they don't track. And case selection's everything. And yeah, that's it. That's all I got. Thank you. Thank you. Any questions? Anyone? Yeah.
Can you show me, because I see this happen all the time.
Yeah.
To me, but when we do exposure bonds with Invisalign,
Yeah.
how do you lock?
I don't do one with Invisalign.
Okay, because I know some people that do.
Yeah.
Okay.
So I know people that do that. What you could do is you need a palatal bar, some kind of a palatal bar, maybe with a hook. You need some sort of auxiliary, or you have to do, if you don't have an auxiliary, you have to have an open exposure. If you have an open exposure, then you can have the patient run rubber bands from the canine down to the bottom tooth, or down to like some kind of a button on the upper.
Yeah, sometimes they have me put in a tab. Use that against me.
Oh, yeah. Okay. So they run it to the TAD, and then they finish it with, yeah.
No, I don't see it
Yeah.
after that, right?
Right, that's the thing, yeah.
I don't know how it's finished off.
You know, I will tell you, with canine impactions, the biggest challenge, and it's like so frustrating, like I used to feel like, oh, I'm just so good at bringing these in, it's just so great, I love palatal canine exposures, bringing them in, and then I see like, you finish him and you struggle with that buccal root torque on the canine, and then you see him like 6 months later, and maybe the kid didn't wear the retainer or even wore the retainer okay. Now the tooth is completely like lingual relapse. So that to me is very frustrating. So I cannot imagine getting even more buccal root torque than I'm getting with bracelet. I can't imagine getting that with Invisalign. Maybe you get more buccal root torque with Invisalign. So anyway, I feel like the finish would be challenging.
And then the other question, let's say they finish, they're still growing, you've held the space with the final tray. Now we put an implant and have a healing color. How much can we effectively remove that before the
Remove.
So you have to relieve it for it to fit over the healing collar, right? How much relief do you get in their final tray and not screw it up? If it's got any mobility, obviously.
Oh, to cut the tray? You're talking about
Yeah.
trimming the tray?
Right.
You can trim half of the tooth on the tray.
Half of the tooth? Okay.
But you usually don't need that much. So are you talking about, so you're
So you
clearing
got
the healing
implant
cap?
in, and it's oftentimes in that space that Invisalign comes down
Oh yeah,
in there.
just trim that pontic.
Okay.
You could leave like about half of the tooth and your aligner will still be fine. But usually in those cases, I trim them for them, and it's like you just need like 0.5 millimeter clearance from the healing cap, right? Yeah, like
make sure
0.5
it's
millimeter or
just
so.
It's just as long as it's
You don't
massive.
want it to push, yeah. And then I think about sometimes like if they clench, like is it gonna touch the healing cap? So anyway, yeah. All right, yeah.
Quick reminder, our next meeting is